Hey, Corby.
Yeah.
McKenna and I are on our way. We're just getting breakfast, so we didn't want to be late, so we called in.
Okay. Perfect.
Goodbye.
Awesome. Okay. Fantastic. Okay. So let's see. Today we're going to be talking about pharmacotherapy for viral, fungal, tuberculosis, malaria, parasites, and HIV. It's a lot. It goes over 3 chapters, which I get is a lot. But 29 is the HIV chapter, and we're just going to just touch on it. So anyway, let's start with anti-tuberculars, antifungals, and antivirals. These are all covered in chapter 27. Good times on page, I'll tell you the page. 374 is where it starts. So, anti-tuberculars through 374 to 379. So, we've all heard of tuberculosis, right? It's a respiratory infection, exhibits both active and latent stages. We get tested for it all the time in nursing school. That's right. Now, incidence has declined. It used to run rapid through really a lot through Europe, especially in London. That was like the TB capital of the world. And it just kind of ran rapid through everywhere until about the mid 1980s. Wait, no. And then it started declining. I read that wrong. And then starting about the mid 1980s, we started to see more and more cases of it. And that is due to a couple of factors. One is the appearance of HIV, because HIV and tuberculosis don't necessarily go hand in hand, but HIV patients have a very high risk of getting tuberculosis. So you do see them together a lot. You get the increased immigration and travel, right, with the easier modes of transportation. And then we've been seeing a resistant strain of tuberculosis, which makes it even harder to eradicate. So, according to the U.S. Department of Health and Human Services, TB is one of the world's leading causes of death due to infectious diseases in persons older than 5 years of age. So, one interesting thing, you guys have the 9th edition book of pharmacology. They have since come out with a 10th edition. And so here on my slide, it says each year about 9 million people develop TB and 2 million die of it. So in the new book, which is a few years newer, a handful of years newer, it says that 10 million develop TB, so more people. However, 1.3 million die. So we're getting a better handle on it, but it's still not, eradicated per se. And then in that 10th edition book, it also says in 2018 in the U.S., there were 9,029 TB cases. So in the U.S., we don't see it hardly at all. We get tested for it all the time, but we don't see it very often. But it does happen. I remember I had to get TB tested for this job, and it was only a few months ago. And I work at the hospital, so I ran to the hospital thinking that maybe they could test me for it, and they don't. But as I was walking in, a doctor had walked, like we had passed, and I heard him say, I need to be tested because I've been exposed to TB. So even here in Little Ogden, Utah, Kaysville, that was Ogden, but you can every once in a while come across it. And if we do have a tuberculosis patient, where are you going to find them? In a hospital. Yeah. But like where in the hospital are you going to find them? What kind of room are they going to be in? The negative pressure room. Yep. And you're going to be wearing a PAPR. All that good stuff. Okay. So it is spread respiratory route through the airborne droplet, which is why you're going to be wearing a PAPR if you suspect tuberculosis. So the organism can remain alive for hours outside of the body. However, it needs a living host to continue to survive and reproduce. So, and then if left untreated, you can spread it, obviously. So here's a couple. I'm not good with x-rays. I have a hard time reading x-rays personally, but here are a couple pictures. One on the, let's see, on the left that you're looking at, that's a normal x-ray. And they always say like the black parts is air. Air is dark on x-rays. And so here you can see like all of these like little white blotches everywhere. That's where air can't be. And so that's where the tuberculosis is. Okay, so who's at high risk? Well, anyone who's in close contact with anyone who's infected, right? That's with anyone. Anyone who's immunocompromised, who would that include? What kind of people would that include?
They're on steroids, isn't it?
Yes, those that are on steroids.
They're like on chemo.
Chemo, cancer patients. Anything else? I already talked about one group of patients.
What about like HIV and AIDS?
Yes, HIV and AIDS.
What about asthmatics? Are they, or like smokers that just go along, are they more susceptible or no?
That's a good question. They weren't on the list, but I can see an argument for that. I don't know if they're necessarily more susceptible to getting it, but if they get it, it's probably going to be worse on them. It's going to take a harder toll with asthmatics and smokers. Anyone else? Maybe if they're in some kind of organ failure, like renal failure or hepatic failure or something like that, right? So anyone who's immunocompromised, anyone taking immunosuppressants, people with transplants, stuff like that, anyone who's immunocompromised. So persons living and working in high-risk residential settings, those residential settings are like nursing homes with people that have TB, prisons, homeless shelters. This is more of a disease that kind of goes through the really poor, like it really affects the really poor people. We don't see it in the U.S. because we're more of a first world country. So you're going to see it in like third world countries where they're really poor, they're not very clean, they're malnutritioned, stuff like that. Illegal drug users. And then, of course, healthcare workers who serve high-risk patients are going to be high risk as well. Okay. Symptoms. So you get anorexia, cough with blood-tinged sputum, chest pain, fever, night sweats, weight loss. One thing I think it's your book. I read a couple things, but I think your book says it in here too, that it's because it kind of goes through all the poor and not dirty, but poor and not as clean types of economies. They don't necessarily, like you see a lot of these things like the night sweats, the weight loss, the anorexia, just based on them being in their situation. Does that make sense? Like their malnutrition, they're going to get weight loss. You're getting the night sweats. So sometimes a lot of these people won't realize that it's TB that they have. They just kind of contribute it to their, situation, what they have. So you can get patients that are asymptomatic. And then as the disease progresses, and it progresses slowly, you can see the disease advance more and more. Like we talked about, symptoms are non-specific, so sometimes it's hard to pinpoint what it is. Cough becomes progressively worse, and then produces infectious sputum, and then it's coughed out into the air. So There is a vaccine for this. However, it's not used in the US just because it's not, like, we only had 9,000 cases in 2008 in the whole US. So we got it pretty controlled here, but it is used in other parts of the world. And so it's not uncommon to have people who have gotten the vaccine come over and be tested for TB. And if you have the vaccine and you're tested for TB, like that skin test, it'll come back positive. So anyway, something to know. And then ways to test it, you have your TB, the skin test, the blood test, chest x-rays, and then a sputum sample. Any questions there? All right, so how are we going to treat this tuberculosis now that we have? Let's pretend we have it. Anyway, so how are we going to do it? So it requires a special dosing regimen and schedules, and it requires multiple drugs, anywhere from 2 to 7 different types of medications. Okay, a combination drug therapy is necessary because of the resistance that can happen, because it's so. Do you need something? Because it does grow so slow, it has the opportunity, if you just are taking one medication, it has the opportunity to develop resistance to it. So if you have a whole bunch of different ones, you're hitting them from all different sides, it will help cure it faster. However, when I say faster, it still takes a long period of time. So the initial phase of therapy that kills the actively dividing tuberculins takes at least 2 months. So you'll be on medication for at least 2 months, multiple medications for at least 2 months. And then you have a continuation phase, which they may or may not change medications, kind of depends, where you're looking at taking those for more than 4 months and up to 2 years. So this is a really long multi-drug therapy. Okay. All right. So these drugs can also be used for preventing the disease. They're used for prophylaxis as well. So prophylaxis therapy would be used for those in close contact of people who've had it. Those who are immunocompromised can also receive some preventative treatment. If you have someone that tests positive in your household, you will be put on it. You'll be put on some of this medication prophylactically. Okay. See, and this one says 92, just over 9,200 cases in 2016. So it's getting less and less. Okay. So the first line or primary drug therapy is the most effective and the safest. There is a second line. It takes longer. It is more expensive, and it has a lot more risk for toxicity and side effects. So the drugs we're going to talk about: isoniazid or INH, rifampin, ethambutol, and pyrazinamide. So those are the 4 first line drugs that are given, and they're given in a combination. So you'll be taking definitely more than 1, maybe 3, maybe all 4. Okay. Now, when you get to the second group, that's when, pretty much when people on the first line drugs are non-compliant. That's when you move to the second group of medications. And like I said, they're greater toxicity, and higher risk for worse side effects. These are your fluoroquinolones. Who can tell me a fluoroquinolone? Anyone remember? Fluoroquinolone. What medication is a fluoroquinolone? They end in fluoxetines.
Not unknown.
No, it is. But they end in fluoxetine. Now, does that ring any bells?
Nope. Finals gonna be so great.
Levofloxacin. Yep.
Got that? Same thing there.
Ciprofloxacin or Cipro. Right, and then there's ofloxacin. Anyway, fluoroquinolones and then the aminoglycosides, which are, we really didn't cover those a whole lot in the antibiotic world. That's the streptomycin, the kanamycin, and the amikacin. Amikacin? I think that's how you say it.
Sure. Nailed it. Yeah. Confidence, never know.
Okay, so then the pharmacotherapy with everything, it depends on drug sensitivity, disease stage, the patient's immune status. It's very patient specific. Okay, culture and sensitivity should be obtained. We all know that, right? Before you start any type of antibiotics, I don't care what it is, culture and sensitivity before you start it. But with tuberculosis, the culture and sensitivity can take weeks and weeks. And so instead of holding off for those long weeks, they're just going to start what they think is going to be the best, change it up if they need to. Okay, so a major concern with the pharmacotherapy is compliance. Who's going to want to be taking multiple medications? And I know some people do on a daily basis anyway, but antibiotics for months and months and months. Plus, we're talking about a culture or an economic status, kind of like this guy, right? So they're going to have a tough time taking these medications for very long periods of time.
Is it easy for for cultures to get all these antibiotics?
No.
Doctors with no borders.
Yeah, so there are a lot of things that that contribute to problems. So obviously, having the healthcare system available to be tested for it, right? And then having the medications available, and then being able to pay for the medications, because you get, especially if you're not compliant with the first line, the second line, and more drugs that you're having to go on to, they're going to cost more money. So it's going to be more expensive. It's going to be a long road. You're going to have to buy a whole bunch month after month after month. So non-compliance is the most common cause of treatment failure. Okay. So what they do for the high-risk patients of non-compliance, they participate in what's called a DOT, directly observed therapy. So kind of like what this guy does. I'm sure this guy goes around and gives meds to the people and actually watches them take it to make sure that they take it.
Oh. Well, that makes sense why the resistance is so high. They don't take it.
Yeah. Or if they skip doses because they're trying to make it last longer, if they're like, oh, well, I'm going to take it every other day, make, this 30-day supply last 60, that's not going to cut it either. Right? So, and they do the DOT, the direct observation therapy, that helps stop the resistant strain as well, and helps stop producing more resistant strains of this tuberculosis. Okay, so special populations. In pregnant patients, they are treated as if they are not pregnant because the the benefits outweigh the risks. The benefits of taking the medications and stuff outweigh the risks of having the tuberculosis. And pregnant women can pass it on to their infants too. Okay. All except for pyrazinamide. That one is usually avoided with pregnant women, but everything else is pretty much game. Okay. And then streptomycin, because it is an aminoglycoside, it has that ototoxicity. So that can't be given, or we're going to have problems with hearing in the newborns. Okay. And then therapy can continue during lactation. In pediatric patients, when they have tuberculosis, they tend to get sicker faster. And so it's really important to educate parents that if the therapy is stopped, the child will get sick again and it will advance faster. And then the homeless and foreign-born, they just have a problem of lack of resources and reduced public health options. So anyway, what's the word? I'm trying to think of a word. I can't think of it. Sorry. Okay. I know Zid. Isonizid. Isonizid. There we go. INH. It does not mean it's inhaled. I know INH is kind of like the abbreviation for inhalation. That's not what this is. It's just a shortened of the medication name.
There's no H. Why?
It's probably like I don't have any idea. I have no explanation for any of these drug names. You could put INH. I don't know. One thing to keep in mind with this INH is it does cause a deficiency of pyridoxine, so vitamin B6. So, what do you think if this causes a pyridoxine deficiency? What do you think you're going to do for the patient? Close, B6. Yep. So we're going to be giving them a supplement somehow of pyridoxine so that they can still get that nutrition. Okay. It also can cause some peripheral neuropathy. So they're going to want to watch for like numbness or tingling in the arms. And if they have the deficiency of vitamin B6, it makes the neuropathy worse. Any questions on that? Okay, drugs similar to the INH, we talked about ethambutol. A lot of these medications have to be given daily anyway. Pyrazinamide, and then rifampin. Rifampin is, as far as the INH and ethambutol and the PZA, those are usually just tuberculosis specific. I haven't seen them used in anything else. Now, rifampin is used to treat meningitis as well. And leprosy, we don't see very much leprosy around here. But I have seen it used in the hospital as a broad spectrum antibiotic. So you can use that for other things. One thing to keep in mind is it turns body fluids orange. So sweat, it'll color their shirts. Also, one thing to keep in mind with this is if any of the patients taking rifampin for anything, they wear contacts, it will dye their contacts. I'll need to check that you'll need to know that, but just overall, it's kind of a cool thing to know to be a good nurse. Any questions on tuberculosis?
So the only drug that you have listed in the chapter for that is the isoniazid?
Yep. And if there's anything else, I'll put it on the clarification document. But move on to antifungals, because those are fun.
I'll give you $10 if you extend the med for Friday. Then I can actually introduce someone who takes more than 5 minutes.
It shouldn't be hard.
While we're on this subject, I did word for word what the person was saying, and it's pretty good to me.
That's fine.
Okay, I'm like.
I think there is a section after each med. Isn't there a section that'll say like what you would teach? Yeah. So yeah, I want what the patient says or what whoever it is, what they say, and then like what you would teach. Because if they're like, oh, I take this Colace for my blood pressure, and you're just like, sure, you would definitely correct that.
So, like, no one in my family is on, like, any type of medication, and, like, I don't have any grandparents. So, like, should I just do it on, like, a patient I had at the hospital?
If you asked them about their meds, you could have done that.
Sorry, Greg.
Yeah, but they only have, like, 6 or 7. I don't know, maybe that's something I can talk to you after class about.
Okay.
So no $10 before me? You're welcome, man.
I'll say, and I've had it happen multiple times through the semester, it's really frustrating when you guys come to me with problems like this at the last second. Like if you would have come to me like a week ago or 2 weeks ago, like it would have been, like we could have figured something out. It would have been awesome. Like the video you guys talked about with the Zoom, like you told me after the test that it was never posted. I'm like, why didn't you tell me? So, like, if you guys see I know we're at the end of the semester, but if you guys see something or have any problems with something, don't wait till the last minute to tell me. Might be a little, too late to say that to you guys, but anyway. Okay, so fungal infections. So these are your mycoses, tinnias, or candidiasis. Is that a word? Candidiasis? Like, oh yeah, is diasis, is that I don't know what the,
Maybe it's
Plural.
like single and plural. Single and plural?
I don't know. Anyway, so fungal infections. So fungal infections are known as opportunistic infections. They are very uncommon with people with healthy immune systems. And they're opportunistic. If something goes awry in the body, if the normal flora is messed up, that's when you see these fungal infections jump into play. They can be single-celled or multi-celled organisms. Let's see. They grow slow. And some of them, especially if they get like in the toenails and stuff, they're really hard to get rid of and they take a really long time. Patients with suppressed immune systems, especially with HIV and AIDS, can experience frequent fungal infections. So what kind of people are we talking about again? People with suppressed immune systems. Yep. Transplants, steroids, chemo. And then with the candidiasis, that's you're gonna see like vaginal fungal infections. And so you get those a lot with antibiotic treatments, right? So if you're on antibiotics, you can get the opportunistic infections. Okay, so they can be classified as superficial, subcutaneous, or systemic. So superficial is considered the scalp, the skin, the nails, even the mucous membranes, like the oral cavity and the vagina. And then you have your subcutaneous ones that affect the deeper layers of the skin. You see those a lot with people working with the soil, in regions where people are barefoot. And then there's a lot of different types of fungal infections. So we have the topical fungal treatments, we have the subcutaneous fungal treatments, and then we have our systemic fungal treatments. And so topical antifungal preparations don't go past like the first skin layer. So if you have anything other than a superficial, you're going to have to get something a little more. You have to have a systemic medication versus a direct topical. And then systemic ones are pretty bad. They can affect, I mean, it's systemic. It can affect the whole body. Okay. These are less common. You don't see them very often at all, and require aggressive treatment. So, Cam, you're a true nurse to see that and be like,
Yeah,
nope,
I'm
I'm
like,
still
"Well, you guys-"
eating. It's fine.
Yeah, no, I'm.
She's eating a waffle with whipped cream on it. And we likened it to the to the foot over here. Okay. So, superficial infections can occur in any patient, not just those that are immunosuppressed. That the superficial kind you can get. For the anything other than just the topical superficial ones, you're going to need PO drugs or IV drugs to get if you have one that's deeper or systemic. And we all know that bad things grow best in warm, moist environments, right? Yeah. That was an athlete's foot, by the way. A severe case of athlete's foot. Okay. So systemic or invasive fungal diseases can require intensive pharmacotherapy for extended periods of time. Let's see. We talked about the corticosteroids, excessive burns, antineoplastic drugs, and then those you need to be careful with involving vascular catheters or organ transplants. Okay, and because the fungus is slow growing, a lot of the therapy takes months. And some of them are really bad. Like we're going to learn about one that is pretty fantastic that needs close observation. Okay. All right, so these cellular organelles and their metabolic pathways are very similar to those of us humans rather than bacteria. So antibiotics are not effective for fungal infections. I repeat, antibiotics are not effective for fungal infections. It's not going to work, not going to do anything. Okay? But like antibiotics, antifungal drugs can slow the growth, so they're fungistatic, or they can kill them, which is fungicidal. And there's 5 classifications. You have your polyenes, your azoles, N-metabolites, quinocandids, and then just some miscellaneous antifungals. And the ones in blue are the ones on your list. You haven't caught on to that yet. Okay, so polyenes. First one we're going to talk about is amphotericin B. This is an IV-only medication reserved for severe systemic infections. It's effective against numerous fungi, and it makes the cell membrane increasingly permeable, so the cell of the fungi just leaks out. It's very nephrotoxic, so you have to keep a close eye on the labs. It also can cause, if I'm correct here, it can cause some bone marrow problems. And then we have our nice statin, which is probably most of you guys have heard of. Comes in a lot of forms, and it's most commonly used for thrush. This is a picture of thrush. Okay. amphotericin B. It's pretty toxic. So I always, whenever I hear of amphotericin B, I think of amphoterrible B because it's terrible. It works, but it's terrible. Okay, it's only given by IV. Okay, adverse effects, really side effects, and almost every patient gets these ones. They get fevers, chills, vomiting, anorexia, headache, shortness of, and then more severe shortness of breath and tachypnea. You get phlebitis, very common, and can cause nephrotoxicity. So knowing that every patient, pretty much every patient is going to experience some form of fever, chills, vomiting, anorexia, headache, shortness of breath. What can you do before you give medication? Educate. Educate's huge. Absolutely educate the patient so that they know that they're not coming down with a new something or another. It's the medication. But what were you saying, McKenna? Treat them. Pre-treat them. What kind of things are going to help with that? With those symptoms? Acetaminophen. Anything else? What kind of medications would you pre-treat your patient with? Right, antiemetics. Marion, Megan, good job. Zofran, Kim?
Okay.
Zofran is used all the time for everything. Okay, yeah, so maybe Zofran, antiemetic, antipyretic, and then maybe some diphenhydramine. Maybe. Yep, oxygen for the shortness of breath. Yep. And then like Kim said, education is huge, just so that they know what to expect. It's less of a surprise and it's actually less severe to the patient if they know what to expect than having it just come on them. Okay, because of the phlebitis, you're going to want to monitor the patient closely, and it will be infused very slowly. You can get bad things like hypotension, hypokalemia, and shock if it's given too fast. And then the kidney function, so you're going to want to monitor their eyes and nose, BUN, creatinine, and CBC. Okay, here's our nice statin. To be a good nurse, you need to know that it comes in very many forms, such as creams, ointments, suspensions, powders, tablets, lozenges, a lot of different forms. Okay, it's actually one of the safest pretty much drugs out there. Like the only contraindication is if you're hypersensitive to it, if you're already allergic to it. The only drug interaction is an azole antifungal. So you don't want to be taking two antifungals together in this case. It just decreases the effects. And then just like minor skin irritation, potentially. I haven't even seen that happen. So, and then POs, maybe some nausea, vomiting, diarrhea. But that's like with every med, right? So, relatively safe, used all the time, especially on infants, right? They're the ones that are most likely to get thrush or the little bum rash that might need some nice statin. So, before we move on, who knows or who has given nice statin to a baby and knows how to give it? Very carefully. Anyone online? Anyone? So if you're given nice statin, so these are all pretty much, let me see if I can go back. Creams, ointments, suspensions, powders. Those are all topical, right? Even the suspension, because you want it to coat the mouth. You want it all topical. So if you're giving a baby a suspension because they have thrush and you're putting it in their mouth, are you going to want to like have them eat right after? No. All these topical things only work if they're in contact with whatever they need to treat, right? If you put on a cream and then change their bum 5 minutes later and don't reapply it, it's not going to work, right? You don't want to wipe it off. You don't want to give them a drink. You don't want to do anything like that. You want to keep it on as long as possible, which I think probably, oh no, here we go. Okay, so patient is admitted to ICU for fungal infections. Amphotericol B has been ordered. So what types of things are you going to, I think there's just 5. What types of things are you probably going to see if it's given too quickly?
All the above.
Not all of the above, no. Just hypotension, hypokalemia, and shock. Yep. Yeah, if you can prevent your patient from going into shock, that's probably a good thing. Okay, your azoles. Azoles are the drug of choice for a lot of fungal stuff. It's also pretty favorably safe. It is the largest and most versatile group of antifungals. They're broad spectrum. They treat a whole bunch of different ones. They can be administered PO. They have a spectrum similar to amphotericin B, but are considerably less toxic. But as far as I know, these aren't given IV. And here we have our fluconazole, or diflucan. It's, as far as outpatient, it's used pretty often for vaginal fungal infections. You guys okay?
Yeah.
Okay.
Sorry.
Fluconazole can be given IV. I've seen that given IV. Ketoconazole is also in this group. It's a really good one too. But on your list is just fluconazole. Let's see. Anything on here? Just a lot of these meds are renal. Can hurt the kidneys, so you want to monitor your BUN and creatinine. Your eyes and nose. That's going to be the first telltale sign for your BUN and creatinine. If there's any problem. Incompatible with a lot of drugs when given IV. All right, here's the nice statin one. So, order for treatment of thrush in a 6-week-old infant. Which instructions should the caregiver receive? So, give the infant a small amount of water after feeding and before the drug to rinse the mouth. Using an applicator or syringe, distribute the solution around the mouth and tongue, allowing the infant to swallow the remainder. Fill the suspension so it has a better taste. Give the suspension before feeding the infant to prevent adverse GI effects. Any other?
Oh, it's like all the blood. I didn't read that clearly. I like the first one.
Olivia, that's a good question. I have only seen it. It might have some of them might have a blue tint to it. I've only seen it. It's usually just white, but depending on what the sore looks like before you put it on, I could see it turning maybe a blue color.
one.
One is for sure what?
Before we. Only 6 weeks old.
What about a 6-week-old McKenna?
And has water.
Yeah, you don't give water to a 6-week-old.
No?
No.
Shit, it's gonna be 6 weeks old.
No. They shouldn't have free water till they're, about 6 months. At least 3. But yeah, when they're that little, they should not have any free water.
They can have water, but they can swallow it pretty much.
It's not, it's the water. It's not. Like, because, I mean, if you think about it, like you mix your formula, you have a bunch of water and you mix the formula. So technically they're drinking water. But free water, just plain water. They shouldn't be having anything just plain water. No, it's just it's the nutritional factor in it. It has none. And so the body doesn't really know what to do with it at that point. Okay. Yeah, so we talked about not giving infants water. Chill the suspension, giving it a better taste. I'm not sure what it tastes like, but I've never had a problem administering the medication. And give the suspension before feeding the infant. So we talked about we want to keep it touching the surface as long as possible. So if we give the medication and then let them feed, that breast milk, the formula, whatever they're eating is going to just wash it all off. So it's not going to do any good. So we want to use an applicator or a syringe, distribute the solution around the mouth and tongue so it's coating everything. And sometimes the thrush will go way back in the back of the throat. So having them swallow it, it's very safe medication. They can swallow it and it'll coat down the back of their throat as well. Sometimes the instructions will say to spit it out. With Nystatin, it doesn't matter. Oh yeah, there was one more. Sorry. And you wouldn't add it to the bottle. You can do that with other meds, not this one. It's just 2.
Okay.
I guess technically you could put 3, but I don't know. Infants don't usually like cold stuff in their mouth. Okay. Antivirals. Any questions about antifungals?
We need to know the other classifications.
3
Other, right?
Yeah, 3 other ones. I don't think so. Well, don't pretend there's only 2. There's more. Read about them for sure. But as far as medications, those are the only medications specifically we're going over. All right. Viruses. We're all very well versed in the last year about viruses, right? They're smaller than a cell. They're not considered to be alive. They can infect bacteria, plants, animals, humans, by entering the host and then replicating. They're technically intracellular parasites. And then a mature infective virus is called a virion. This is their replication cycle. So they attach, they penetrate the cell, they do their DNA replication, they get all together, and then they lyse the cell and go out and infect other ones. Okay. So, antiviral drugs target a specific viral structure or stage of its replication cycle. So, you're going to get maybe some antivirals that affect like this DNA stage, or maybe this stage, or maybe it'll affect this stage. So some of them, they'll affect different stages. Okay, some viral infections cause acute symptoms. and are self-limiting. What kind of things are we talking about with that? What kind of illnesses or viruses that we have that we deal with that are self-limiting? A cold, flu, any of those, like a lot of respiratory viruses, RSV, stuff like that, rhinovirus. What was that? Self-limiting. So they run their course and they go away. There's no permanent effects that we have from them. No drug therapies needed. Self-limiting. So we get a cold, we're down for a few days, and then it goes away. Do you have any problems with the cold that you had 3 years ago? No long-lasting effects, right? So they're self-limiting. They just make us sick and then they go away. They're pretty annoying. Okay. You can, and if you have comorbidities, it can make it worse. Like with asthma and stuff, a lot of kids have, like they get RSV or even rhinovirus. Like their asthma, they have asthma exacerbations, and it takes a lot longer, and they can have a little longer lasting effects. But typically, there's no permanent effects. This COVID's a little different, but some viral infections are not self-limiting and they need therapy to help prevent infection or alleviate symptoms. So, and then another way to treat viral infection is to boost the immune system with vaccines and interferon. Okay. Interferon is like a booster. Yeah. It's like a.
I was thinking one of them. I need to know for the test. How about that? I'm so excited about it.
Just to boost the immune system, vaccines is the number one thing.
All right.
Okay. We have vaccines for a lot of viruses, except for the cold. If you find a vaccine for the common cold, you would be the richest person on the planet. The planet. Okay, so flu, influenza, our fabulous influenza. Okay, so we have some drugs that can help. Well, it's arguable, but they're considered to help with influenza virus. So you get all these fantastic symptoms with the flu, right? Tiredness, body aches, sore throat, cough, runny nose, fever, headaches. You feel like jizz. Exactly. You feel like that guy. Okay. They're easily transmittable via droplet and hand-to-hand contact. Right? For an immunosuppressed patient, flu infection can be fatal. And even those that aren't, every once in a while in the news, you'll get reports of like some normal random person getting the flu and dying. Right? What are you saying?
Well, just like all year we've been hearing how many people died from the flu
There's still a lot of people that die from the flu. I don't know. I have a hard time with that comparison because the flu is a flu, and if you already have it, I don't know. Like a lot of people, I can see people that
generally die from the flu and this year and something else. Right now they're like, oh yeah, people do that.
Yeah. Get your flu shot. So there's 3 strains of flu, right? There's the influenza A, influenza B, influenza C, and then they have their substrains with the H and the N, right? So, and then you guys, I'm sure with the coronavirus, you guys have all heard of the flu outbreak of 1919. It actually happened between 1918 to 1920. So it was 2 years between them. It killed 20 to 50 million people worldwide. they're thinking maybe about 500 million people were infected.
What was the population back then? Was that like a quarter of the people?
Oh, I don't know. Oh, really? A quarter of the world's population back then?
No, Obama.
So it'd be like two. It'd be like 2 billion people being infected now, right? If there were 500,000. Yeah. Oh my gosh. Speaking of which, so my son, sorry to get a tiny bit off topic. So my son was watching The Office. He's really into The Office lately. So he'll just like sit and binge The Office. Well, there was one episode, I don't even know what episode it was. Yes, when Dwight says, there's too many people in the world, we need a new plague. I was like, oh man. So the 1919 outbreak of flu was the H1N1, which is still around today.
So 100 years ago would be a joke.
Pretty much. Pretty much. So here's your A, B, and C's. A is the most common, most severe. B is less common, milder symptoms, and then C is even less and produces symptoms similar to the common cold. And then you have your subtypes, and we all know how the flu vaccine is. Me or something else? Okay. You know how
She sent me this. It's a wow. She said wow, and then no, it's a wow. 11 Wilson space on owl. Wow.
So every year they just try to guess, which I'm sure there's more than just guessing. There's some scientific whatever, but they just guess which strains they think are gonna cause problems. And some shots I think have 3 and some have 4, something, I don't know.
Are they all type A in the flu shot, or
No,
they could be B and C?
no. So I know like last year there was, I think, I know there was a type A and a type B, and I think there was 2 of one of them and then one of the other one. So usually type C, they usually don't put any type C's in there because it's just really mild. You get milder symptoms. So it's usually A's and B's and their substrates, subtypes. Okay. So the reason why the flu just is so great is they have these single-stranded RNA genetic material things, and they have like these spikes. They produce these protein spikes, and that's kind of how they replicate and stuff. And what they do is they change these spikes, and so they just like mutate every time and change them. And so
Do we need to know those words? Is that why they're underlined?
I don't think so. They're just fun to say. Go ahead and pick one and say it 3 times.
I'm so stuck on the last word. Dioms.
Hey, that's pretty good.
Oh, don't worry, I felt it.
So mutations of these spikes create a new influenza strain, and so that's why they just evade us every time. Okay, so the best approach to the flu is to get a vaccine, right? There's 2 different kinds. There's the inactivated and then the live attenuated. The live attenuated, when it first came out, it was really, really popular, especially among kids, but I don't think they use it quite. It's not as popular so much anymore. And then we talked, then, those at high risk should get it. And then, of course, healthcare workers. Because that's what we do. Okay, so drug for the flu virus. Tamiflu. You've all heard of Tamiflu, right? Heard of, yes. It's been in the news quite often. It's very, very popular. It was thought when it very first came out and they were like, what, treatment for the flu? This is great. It was like kind of considered a miracle drug. And now that we've been using it for quite a few years, and more studies have come out, and we're not seeing the miracle that it was supposed to be. It's really not that great. I know.
I hate taking that. I can shove them down my throats.
I know. So, a personal experience with that. So last, put your phones away. You're so distracting. The last spring, my kids got it.
I'm actually leaving stuff in school, believe it or not.
Oh,
Medication was.
oh, okay. But so my kids, I have 6 people in my family. 3 ended up getting the flu B. And so I kind of hummed and hawed because they were like, we can get you Tamiflu. And it's given prophylactically too. So I was like, what do I do? And it costs about $70-ish a person for, huh?
It's expensive. They only give you like 12 little packets.
Yeah, so it's like a 5-day treatment. And it costs like $70, give or take a little bit, depending on where you go. So
Is that with insurance?
Yeah.
Oh,
yeah. So, I mean, you think I got 6 people to treat.
there goes your Christmas present.
So I hummed and hawed. Now, the one thing to be a good nurse, you need to know, Tamiflu should be started, any of these flu medications, any of them, should be given within 48 hours of the first symptoms. So that's kind of where this gets a little funky, because you'll get people that are like, been sick for 4 days, decide to go in and get tested. Well, now they've gone 4 days, which is 96 hours. And so they're past when Tamiflu is gonna work.
And I feel like that's the biggest issue with everyone. Like, no one wants to go. And if I already know it's that much money, and I didn't know that you have to be in there within 48 hours. Because I usually go to the doctor after like 2 or 3 days of feeling bad.
Right? Yeah.
So it's like, and I don't want to pay $80 for something that's not even gonna work.
Right. And a lot of people show it only takes maybe a day off of your sickness. Maybe you'll get feeling better a day. With my experience with 3 of my kids, I had one kid that was 2 days ahead of the rest, the other 2. And so they all had Tamiflu, and then the other 3 of us had Tamiflu, which I'm like, I don't know if this is like, you'd think if I was to get the flu, I would have already had it because my other kids have it. But the 3 of us didn't get the flu. And I don't know if I would contribute that to Tamiflu, because my youngest one took about a day and a half of hers and wouldn't take any more because it's not very good tasting. So trying to get a 6-year-old to 5 then, but trying to get a 5-year-old to take this nasty medication. So she didn't even finish hers, but she never got it. My husband and I never got it, and the other 3 kids did. And I only saw, and Carver, I think he got the Tamiflu too, but it was still kind of past the 48 hours. I was like, what the heck, we'll see. And like the other 2 that had it within the time limit, maybe 12 hours difference of them kind of getting up and feeling better from the one who was sick the first. Does that make sense? So I probably saw maybe a 12-hour difference of them feeling better faster than the first one did. It's just very...
Are you basing your statistics off of your kids or off of like an overall study?
So that's my personal experience. As far as having it not work, it's their actual studies saying that it maybe only takes about a day off of your sickness. So you'll be able to go to work like a day sooner, which for some people, $60 is worth it.
The bottom 2 meds, is it saying they're no longer recommended to use those drugs?
Yeah. So amantadine has been used. It's no longer recommended. It's still used though. These 2 are the newest ones, the Tamiflu and Relenza. They're the newest ones. But you still see amantadine given. So it must to get any real effects from it, it must be given within 48 hours. From the flu symptoms, not from being tested. But yeah, studies out there, there's studies showing it's not quite as fantastic as they thought.
Anymore, or it wasn't even, it never was.
It never really was. Yeah. So for some people, it might be worth going back to work that next day. Well, the last, that extra day. Other people. That depends on your situation. So there has been studies that show that people on this medication can have some abnormal behavior with some self-injury and delirium. So you'll definitely want to watch that if you're giving it to a patient in your care. Can cause seizure activity, but it's really, really rare. And it's given prophylactically. And then Relenza, that's an inhaled powder form. This also has to be initiated within 48 hours. And it's good for people age 7 and older, basically, because you get any younger than that and they have a hard time getting, breathing it in and getting good breaths and doing it appropriately. And because it's inhaled, be careful with patients with respiratory disorders.
On the 48 hours, is that just because it's already replicated and it's taking full force at that point that it's not really gonna be helpful? Is that reason? Is that the 48 that way?
Yeah. Yeah, it's just really not that effective if it's given after. Plus, I don't know, I know the flu can last anywhere from 5 days to 2 weeks, but you're already 2 days into it, and then you have to wait another couple for the medication to take effect. You're already halfway through that. Does that make sense? And where the flu is self-limiting anyway. Okay, so patient gets Relenza for flu, but tells the nurse, I think I can hold off on starting this. I don't feel that bad yet. What would be the nurse's best response? Okay. Okay, so yeah, 4. Needs to be started within 48 hours of the onset of symptoms. Okay, do you want to take a break before we jump into herpes? Let's take a 5-minute break. And then we'll jump into herpes. Okay, let's talk about herpes now.
Hell yeah, let's jump into it.
Heck yeah.
This is my favorite subject.
Herpes or HSV.
Got the hoop.
Yes.
What would cause a kid to start getting herpes at the age of how many years old, 10?
Contact with somebody else with it.
Or what? Don't share personal
Like-
items.
Cold sores?
Yeah, that's what I did in 5th grade.
Yeah. So you would have had somebody would have kissed you or touched somebody with an active sore would have had contact with you.
The first time I got in there, I went down my throat.
Yeah. Yeah.
Oh,
That is the worst. Yes.
It's killing.
It kills them and it makes them go blind. Yep.
Those are chapstick.
Yep.
Will it stay on the chapstick for a long time? Or cream or something?
I'm not sure how long it stays, but if you have somebody who has an active sore, stay away from it. And we're going to talk about babies here in a minute too. Woo-woo.
Oh, yeah. Oh, yeah. I haven't felt it either. I had like
Okay.
4 when I went. Yeah.
So they cause blister-like lesions on the skin. You can get them on your genitals and mucous membranes. It's acquired through direct physical contact from an infected person. It can be transmitted from mom to newborn. Neonatal herpes has a 50% mortality rate. Yes. So if there's an infant that comes in with if an infant comes in with a febrile infant, this is one of these medications they treat for this as well. Like, that's one of they do all their tests and then hit them with a whole bunch of antibiotics because they're infants. There's no reason why they should have a fever, except for if it's something generally bad. And so they hit them with a whole bunch of stuff, and HSV is one thing they treat for until they can rule it out because it's really bad. So there's a couple different types of herpes viruses. However, we know most popular type 1 and type 2. So type 1 is the one you get in the eye, mouth, lips. Type 2 is the genital infections. Then you have your cytomegalovirus, your shingles and chickenpox, Epstein-Barr, and then this herpes virus type 6, roseola, yada, yada, yada. So typically the very first time that you're infected and you have an outbreak of herpes, it's the worst. You'll get a really big outbreak. And then anytime after that, it's less severe.
My cousin's got told me had rhodiola.
Yeah, so it's got it's like this middle like kind of lacy type thing. This isn't like type 1 and type 2. It's not something that is latent and then you're going to get an outbreak again. It's more of like a one and done type thing. They're all contagious, but as far as them all being the same, no. That makes sense, because like chickenpox is in this group too, but we don't link chickenpox really to herpes.
So if you have like rhodiola, could you be more prone to having
No.
if you have rhodiola, you would be more prone to having
Okay, humans are believed to be the only reservoir for HSV. Okay, so following its initial entrance, you may have a latent asymptomatic period. So when we talk about herpes, we're talking about type 1 and type 2. Not really any of the other ones. Okay, because I mean we don't have a cure for herpes. We have a vaccine for chickenpox. Mm-hmm. We even have a vaccine, I think, for shingles. Help prevent the reoccurrence of shingles even. So those are a little different. So when we talk about herpes with these, it's type 1 and type 2. Okay. So the infection is lifelong. There's no cure. Okay. A lot of different things can promote an active infection, I guess, or a reoccurrence of these lesions. So we got immunosuppression, physical challenges, or emotional stress. What are maybe some other ones? What other triggers? You know of? And yeah, just general infection. Yep. Menstruation can trigger it.
Oh.
Fatigue. Emotional or physical stress. The sun exposure. Yep. Illness. Yeah. So anything that really kind of affects your immune system a little bit. Okay, so for pharmacological goals for managing herpes, you want to relieve the acute symptoms and then prevent reoccurrence. Okay. So because of the severity of neonatal herpes infections, pregnant women with the infection will be given antivirals. Sometimes they'll be taking, if they have like a genital herpes outbreak when they're going to deliver, sometimes they'll take them C-section. So they don't infect the child. Yeah, they should be able to breastfeed. Okay. So the greatest risk to baby is if mom contracts the infection late in the pregnancy. If it gets into the eyes, it can cause blindness. And then with it can be on the surface of the eye too. Yeah. It's painful. Yep. Yes.
So would they also give antivirals for type 1?
Mm-hmm. Yep. Yeah.
My son's okay. Oh, I don't do too.
Okay. So there's a couple. These are your cyclovirs. The antivirals are your cyclovirs. So you have your valacyclovir, famciclovir, acyclovir. That's the one you're going to see given the most, the acyclovir. They do have some over-the-counter topical. One's called what? Herbex, or maybe someone online knows.
Oh, I know.
Okay, so Shelby, as far as genital herpes goes, the mom can give it to the baby during pregnancy and delivery. The herpes type 1 can be given at any time. Yeah, kisses to the baby. Do not let anyone kiss your babies, please. Please, please, please do not. There was a not too long ago, we had a little baby come in, 3 months old, ended up having the HSV, went to primaries, she was really sick, and she was holding on, and they did a CT of her brain, and there were lesions all in her brain. Oh, it was so sad. It just can't, like herpes in infants is really, really bad. So for the love, do not let anyone kiss your babies, especially if they have an active sore. So IV drugs can be given IV, given to infants. Mm-hmm. As far as I know, it's an actual active sore. So if you have that tingling and you're like, oh, I feel it coming on, at that point it's not. But once the sore develops and it's an active sore, then that's when you can spread it. Yeah. So I know there's 2 topical creams out there that you can get. One of them is like herb something, and then there's another one like in a blue Abreva. Yeah, Abreva's pretty good. Yeah, Herpecin or something. So Shelby, as far as I know, if the mom has an active form of genital herpes, they will deliver the baby C-section, so the baby doesn't come into contact with that. As far as cold sores, you can give that anytime with active lesions. And then it's kind of like chicken pox. I don't exactly know the pathophysiology, but I know when a pregnant woman gets chicken pox, it can be really damaging to the infant. So I'm thinking that's the same with herpes. If she, not necessarily an outbreak, but if it's the first time, like if she contracts it and has the first outbreak of it when she's pregnant, it can somehow harm the fetus too. So.
They don't ever give meds for like mouth or eye. Only topical?
No, you can get PO meds. Yeah.
Oh, okay.
Yeah. So there's a lot of different ways I've seen, like working in a pharmacy, there's a lot of different ways I've seen it prescribed. So people that tend to have lots and lots of outbreaks, I've had them just be on acyclovir all the time. They just take it prophylactically all the time. All the time. Other people, like if they only have an outbreak, like say they're like, I only have an outbreak like every other month, or then they're probably going to get more of a prescription that's like, when you start to feel the tingle, start taking this medication. Does that make sense?
That's what you do for the
Yeah, both Zovirax and Valtrex you can do that with. I'm not super familiar with the Fambir as far as prescription goes. But yeah, so you can take it during an outbreak, you can take it prophylactically. But they do have adverse effects, and so some people just want to take it when they have an outbreak. Other people will take it prophylactically. It kind of depends on the frequency of occurrence. And if the benefits outweigh the risks, I guess, right? So, and then, yeah. You like that? What happens in Vegas doesn't stay in Vegas. So, and then those antivirals work with type 1 and type 2. Here's your acyclovir. Can cause nephrotoxicity. That's like a blanketed statement pretty much for a lot of meds, right? Monitor the frequency of occurrences, assess the lesions, and then monitor your BUN and creatinine with those. So not a whole lot to that. Drugs similar to acyclovir, you've got your Fambir. That one has a longer half-life, so less frequent dosing. I think acyclovir can be up to 2 to 3 times a day, depending on the dose. Can be used prophylactically for genital herpes and a treatment for acute infections. So it can be prophylactic, or you can take it during an outbreak. Same with Valtrex. Okay. So the most effective therapy are these antivirals. We're talking about hepatitis now. I knew I would get them mixed up. I'm like, I need to have a slide in between so that I can tell when I'm going from herpes to hepatitis because the name looks very similar. So hepatitis. Any questions about herpes? Don't kiss your babies, please. Don't let anyone kiss your babies. Don't kiss the babies. I don't know. Maybe I should put one in there. You have a visitor come. They wash their hands, but they have an active sore on their lip. Are you going to let them kiss your baby?
Yes.
The answer is no.
Sorry, you wanted to keep it.
Unless you want a 50-50 chance of that baby living. I don't like those chances at all. Okay, yeah, don't. Because a little baby with, oh, it's sad, guys. It's really sad to see. Okay. So hepatitis. What's hepatitis? Inflammation of the liver. We got liver problems here. Hepatitis can be caused by drugs, alcohol, autoimmune disorders, metabolic diseases, or infection. It used to be caused by blood transfusions as well, before technology came and was like able to screen for that. In fact, that's how, like, somebody's on the roof. Something. Yes. Anyway, that's how my grandpa got hepatitis C, because he was in an accident and needed a blood transfusion. Hepatitis C from that. Anyway, so we don't get hepatitis C from blood transfusions anymore because
When did they start screening for that? Like more than like 15 years.
oh yeah.
Okay.
Yeah. He got his, I want to say he probably had his in like the 1970s ish. Maybe I don't even think 1980s, probably 1970s. But yeah, they've been screening for it for a long time. So definitely more than 15 years. All right, so each infection has their own unique clinical features, but they all invade the hepatocytes and produce the same symptoms. How many knows? How many? Who knows how many different types of hepatitis there are? There's a lot. Depending on your definition of a lot. Does anyone online know? 10? A good guess. I know of 5. Like around. So we have our 3 primaries, our hepatitis A, hepatitis B, hepatitis C. We've all heard about, right? They're all spread different ways. Hepatitis A is how's hepatitis A spread? Fecal oral. Yep. So you see that a lot in restaurants. Okay, hepatitis B and hepatitis C. How are they spread? Then we have hepatitis D and hepatitis E. So here's kind of an overview of all of them, if you're interested. Hepatitis A is pretty self-limiting, right? You'll get sick and then eventually it'll go away. Hepatitis B, hepatitis C are chronic. And I don't know a whole lot about D and E just because they're not very popular. D has a high mortality rate. Okay, do you see that I did talk about vaccines. So hepatitis B, we get that when we're babies, right? Yeah. When you're born, that's one of the vaccines they give. The Hep B. Oh yeah, I remember now. Hepatitis D, you have to have another hepatitis to be able to get hepatitis D. a co-infection is required. I remember that now. Way back when. Okay. Tenofovir. Now, this is also a drug that we're going to revisit when we talk about HIV. So this drug treats hepatitis B and HIV. It's one that will be used for both. So that's why this says monitor for changes in HIV symptoms. You could put hepatitis symptoms. Just kind of depends on what you're using it for. No, it can be used for HIV as well. Hepatitis B. So this is for hepatitis B and HIV. So we're going to talk about this again a little bit later. So, good question. So yes, you use it for Hep B. Now the thing is if they stop using it, yes, that's where you get the exacerbation for the Hep B. Is when you stop using it before you're supposed to, then you'll get that, like Amy said, that rebound exacerbation of hepatitis B. Do not abruptly stop taking this medication. Correct. Now, if an HIV person abruptly stops taking this medication and they don't have Hep B, they're not going to get a Hep B exacerbation, right? Because they don't have it. They're using it for something else. But there are also combination medications that have tenofovir in it. So want to be careful if any of your patients are using combination therapy, not to double up on it. Okay. Any questions about that? This is not in your book because this is just brand new. SARS-CoV-2. That's COVID-19. This is the vid. It's the COVID. It's the Rona. It's the, what other names do we have? So, remdesivir. Who has anybody? I know you guys got a lot of time on your hands. A lot of time. I get it. Has anybody happened to take a little bit of time and research this remdesivir that is considered, as before Friday, treatment for COVID? The U.S. pretty much bought out, when they announced it was like this great thing, they pretty much bought out all the stock. I'm not sure about that. So I did a tiny bit of research on this. So a couple things I learned about this. They tried using this. They were thinking that this would help Ebola when we had the Ebola virus outbreak. And it was a terrible disappointment. So, a couple things that are interesting. So this was fast-tracked for those who haven't done any research or seen the news or anything. This was fast-tracked by the FDA to be approved for a treatment for COVID. Now, if you look into that in the reports that I read, the FDA has a huge panel of people that cover their anti-infectives medications that are developed and want to be approved, right? And it's a big group of people that have doctors and pharmacists and even like consumer, like people that represent like the consumers, and like they have this huge panel of people. And what's supposed to happen to get drugs, part of the process to get drugs approved is they're supposed to go and present it to this panel of people and do what they do. As far as I know, the FDA did not do that for this medication. I think exactly. So Gilead, is that how you say their name? Gilead. Gilead is the company that makes this. And they approached the FDA, and the FDA listened to them and said, yep, sounds good, we're going to approve it. And totally bypassed all their other things. And I totally get it. Like, everybody wants a cure, everybody wants a treatment. We got to do this quickly. But as of Friday, last Friday, the World Health Organization has come out saying not to use this. Saying that it's not effective. Studies are showing it's not effective. It's not. I'm sure there's some cases where it's made it worse, but studies are coming out and they're showing that it doesn't decrease the length of illness. It doesn't decrease the need or not need for intubation. Like, it's really not doing anything.
I thought the whole point of it is that it like prevents it from death. That's what, because I had a patient on Thursday who actually said it's 15 minutes, and the nurse I just said that it doesn't really necessarily help like with the symptoms, it just helps prevent it from death.
Right. Yeah. But it's not showing any it's not showing that it's really that effective, whether you take it on day 1 or day 5. You know what I mean? Like, they're not showing any, on all their studies and everybody they've used it on, they're not showing any type of benefit. That's what I read up yesterday. Anyway, so as of Friday, the World Health Organization has come down and said, we don't recommend this. So
Is this the one they were planning on rolling out and having the health care vaccine?
no, that's the actual vaccine. This is the antiviral that they give to patients when they're hospitalized.
Is that one still on track? Vaccine.
Yeah, as far as I know. And they've come out with there were, I wish I could remember the companies. So there's Pfizer that came out first, right? And then there was another one. And then as I think last week, another company has come out saying that theirs is effective too. So the first one was 90% effective. And the second company came out and said it's 95. And then the third one, I think, came out saying over 90, which isn't very specific. But what do you guys feel about the vaccine? People are quitting their jobs in healthcare because just of the freaking situation. Oh, I don't.
Like, I was only tested like 94 people. 94.
Right.
Doesn't make me feel good. Yeah, that's been like, and we'd be the guinea pigs, which is horrible because if it doesn't have like bad side effects, imagine all the healthcare workers that go down, like the world would fall apart. You laugh.
No, I just said I got a text last night from the hospital that I work at, and they said they were at least 11 nurses short today.
Mm-hmm. But there's lots of people that want to.
And there are lots of people that want to take it.
They should be able to if they want.
Yeah.
The choice, we should be forced to try. I agree. We have I didn't want to be forced to the hospital.
I don't know.
Because it's a new vaccine. It has been proven to actually. Yeah, exactly. That's the other thing. They don't know about the long term.
That's my problem with it. The long term effects.
What if I died? You didn't have any able to do that. Yeah.
So me personally, I'm really hesitant. I'm hesitant about it. I don't know. Megan, were you talking about it's expensive with the remdesivir? It is, because it costs anywhere from $2,300 to $3,200. So yeah, remdesivir, not only do we even know if it works, it's expensive. It's expensive. So yeah, I don't know. It's just, I don't know. I don't know about this stuff. From my understanding, that can be with insurance. I mean, depending on your insurance though. I mean, you're already talking about a hospital bill, because this is just, as far as I know, this is just IV. And so the only way, no, it's just new, and I'm just trying to keep you guys up to date. So as much as I know. So anyway, kind of interesting. It has been around for a hot minute, just because they were trying to use it for the Ebola when that came out a few years ago. But
Do you think if they
Still.
try requiring hospital workers to protesting and stuff?
Yeah.
I was just gonna say.
I think-
a lot of family protested vaccine. People protesting.
yeah, I don't quite understand it, because before this happened, there was a huge anti-vaccine movement happening. Right? I mean, there was a huge anti-vaccine movement happening before this COVID even started. And then it started, and then everybody was like, we need a vaccine, we need a vaccine. So it'll be interesting once it actually rolls out and it's available to the public. It'll be really interesting how those two groups are gonna
That's on the moms of Facebook.
how it's gonna interact. And then you're probably gonna get our educated nurses who kind of know what's happening, like in the middle of it, being like, I don't know what to do. Do I get vaccinated? Do I not get vaccinated? I don't know. I'm kind of in that spot right now. I don't have to make a decision because it's not available to me right now, but eventually I will, and it'll take. Oh, that's so scary to me. Okay. Anyway, I guess that's a whole nother discussion. Chapter 28, antimalarials, antithelminics, and peptides. Hopefully the rest of this should go pretty quickly. Okay. Antimalarials. Well, do I need to go over malaria? Well, I mean, do you guys know about it? Are you like, no, I totally know like what malaria is, how you get it. We're definitely going to talk about how to treat it, but it comes from mosquitoes. Yeah, it's very round. Yeah, Africa. Yep. Okay. Bleh. I'm not gonna ask you like how many cases of malaria were there in 2015. You'll know that now. I'll tell you what you need to know to be a good nurse. Okay, so it talks about the phases after the mosquito infects the human. There's an incubation period. Transmission really is just by controlling the mosquito population. I know there was a huge thing with not only getting medication and treatment over to the third world countries, but also getting like the mosquito netting for where they sleep. Anyway, malaria drugs are for treatment and prophylaxis, okay? And quinine was really the only anti-malaria for some time, but now we have synthetic drugs because that's just what we do, and it has fewer side effects too. Quinine was once thought to help COVID too, by the way. Along with everything else, quinine was. Okay. Quinine. Okay, so when drug-resistant malaria occurs, you need a combination. Chloroquine is commonly prescribed for malaria. And then if resistance occurs to that, then we have mefloquine hydrochloride, or a combination of antimalarials. To be a good nurse, you need to know that antibiotics also treat malaria, which is, don't ask, I don't quite understand it because I know malaria is a protozoa and antibiotics are for bacteria. Somehow it works. I've underlined them and put them in green, so they're not on your list of drugs to know, but they are previous drugs, which are still fair game. Okay. Tetracycline, doxycycline, and clindamycin can be used to help treat malaria. Not the same, but very similar.
Why does everything have the same general symptoms? I have possibly everything. I guess
Hopefully not liver enlargement. I'm assuming that's liver, but it's on the wrong side of his body because there's. Oh, is it spleen?
Okay. Kind of shaped like a stomach.
I know. You think you'd have two? Maybe you gave one away. I don't know. Anyway, so here's all the symptoms of malaria. 3 methods to use to eradicate it. Medicate prophylactically, treat the acute symptoms, and then prevent relapse.
Well, if you medicate prophylactically, doesn't that increase resistance? If you're taking it a lot, you're just like, oh, I'm just gonna take this every day.
Those zones have resistance? Do they build resistance if they're, what is a zone? An old bacteria.
Yeah, it's a.
Do they have resistance then?
They can develop it because you would need a combination of meds to treat it.
Yeah, so then if it's prophylactic,
No? Because you're getting it, you're hitting it before it causes a problem. So chloroquine is slightly different than hydroxychloroquine, but they're still both used.
So my aunt and uncle, they've been in Ecuador for the last 20 years, and they do take this prophylactically.
Yeah. Anybody who is going over any overseas, wherever, if malaria, if they're at a risk for malaria. My cousin and his wife adopted a daughter from Congo. What is it? District of Congo or whatever it's called. And they were there for a month and a half. So they had to take it prophylactically. And anyway, so like if you were to go over on like a thing with Doctors Without Borders or some kind of humanitarian trip, you would be taking this prophylactically. Stuff like this. One thing to know, any patient that is being prescribed this or taking this, it is absolutely toxic to children. They will die if they take it.
And those children going across the border. What about teenagers? Like at what point is it not age going up?
Where they can realize not to take when they realize that, oh, this is medicine and I shouldn't take it.
My kid can take a lid off the town. Oh, you mean like that? Okay.
Yeah, I mean like if they're gonna get into your medication and take more than they're supposed to, it's very easily toxic to them. It doesn't take a whole lot to kill them.
Is it not prescribed to children like malaria or not?
I don't know what they do in Africa. I don't know how they treat or distribute this in Africa. But I don't hear. I'm sure they have some kind of treatment plan for kids that need it. But as far as taking too much,
That's why I'm really good, is that's why I'm close.
you can die of chloroquine. And there's actually people who, I mean, it's toxic to you guys too if you take too much. There was that couple where in Texas or something that was trying to self-medicate their COVID with
I thought it was like.
chloroquine. Well, because it had some chloroquine in it. Maybe. I think it does
I don't
have.
know, there's a lot of times people.
Anyway, and they overdosed and died from chloroquine or hydroxychloroquine, whatever it was. Anyway, yes, so they took it and they died. So anyway, toxic, especially to children. That is the takeaway here. Make sure they keep it out of reach. Some parents' kids, man. I think you already said that. I was trying to get a different form. It didn't work. Okay. Anyway. Anthelmintics. Anthelmintics. These are your worms.
Oh, yeah, with that round one.
Your parasitic worms. I should post you guys some videos on these. Okay, so these are usually in the moist soil where sanitation and hygiene are poor. You can also get worms from undercooked pork. other thing. Oh, look at that! Look at that hookworm. Like he does not look friendly. Most common site for these are in the intestines. A lot of times, so my brother went to Chile on his mission, and he came home and he like throughout his mission and coming home, he like completely lost his appetite. He was skinny anyway, but he was like really skinny. He had like, somebody can like correct me if I'm wrong, but I think you have to have like a 10% body fat to have enough to like cushion your organs, and he was like at 11.
Yeah, it's 10%. When I wrestled there, like it wouldn't drop my weight.
Right. Okay. See, so I'm kind of, and he was like right there, and he was, I mean, he's really tall, so he was like a beanpole. He still is, but they thought for sure coming home from Chile that he had a worm somewhere, and he took medication and they tested for him. They couldn't find anything, but man, usually people will lose weight. They can't gain weight.
Where do you get one of these? Yeah, I was just gonna say, what's the problem?
Yeah.
Out of their anus and they can just. Oh, this is the tank pet. Yeah, they always like pop out their own.
Oh my gosh. Oh man, yeah, these are nasty. I don't know. I don't know why. Ivermectin.
This is really familiar. Hey,
You want to know why?
we've covered this. Headline.
That's probably why.
I don't remember that. I'm just saying that I didn't point, but like we had.
Ivermectin. So the oral use is for that word. Those are actually they can be, what do they call it? River blindness? Have you heard of river blindness? River blindness. It's like that's spread by black flies, and they go and like lay eggs in your like around your eyes. Anyway, and so it gets in the eyes and causes blindness, like for real.
We need to Google some.
I should have got you. But most commonly, because parasites are not, I mean, unless you go overseas, you are not going to get a parasite. Chances are very, very slim. So the topical use here for ivermectin is head lice, which is, you will see that. If you haven't already had kids or had it yourself or know of outbreaks in schools, ivermectin, head lice. But it is anti-parasitic medication. Oh, that was supposed to say peptides. Sorry. What are you looking up? Oh, yeah. Yeah, see? I think they call it river blindness. That's the infected eyeball.
River? Like a
Hey.
long river?
Yeah.
Is that what you said? No, you can see the one in this one. That one's fun.
Kim's looking up pictures of these like little worms in the eyeballs that causes blindness.
Oh, yes. Okay. I see
Yeah, it's a
that.
parasite still. Even though most of the time you see them in the
Okay.
intestines and stuff, you can get them other places. In fact, sometimes you can get them like
Oh, and your stages. Oh, yeah.
stages of it. Anyway, this slide is supposed to say peptides. I apologize. I will fix that.
On the parasite and everything, can they take the ivermectin and prophylaxis? Like, if you go to a place that has the river blindness, can you take it?
That's a good question.
You might not want to.
You
The nematode.
don't want the no. Oh, that's like an actual. Ooh, they're taking it out. I'll have to post videos of these. Oh my gosh, it's a nematode.
I'm gonna wait for it. Look around.
Oh my gosh.
Can you imagine? Woo! Would you like imagine doing that? Like,
Oh my gosh. Prophylactically, that's a good question. I'll find that out. I know for head lice it doesn't. Well, you normally don't do it prophylactically for head lice. You would treat it if you had it. I'll get back to you on that.
those slippery little suckers.
Okay, peptides.
Yeah.
Peptides are antimicrobial. They have bactericidal ability. They kill a range of parasites and viruses. They include antiviral, antimicrobial, antifungal, and antiparasitic on the classification. But two groups of peptides are used as antibiotics, and they're polymyxins and bacitracin. I think we've all heard of that. Did you say that in your nose?
Imagine, you know, she made food in the nose.
Oh, the worm in your nose.
Oh, God. I was like,
I thought you were talking about the bacitracin in your nose, because they do put bacitracin in the nose for those with MRSA
I've heard that
stuff.
like from the hospital? Oh. Oh, they're like, what are we gonna do about Bassy? I'm like,
So peptides are like their own class.
Yeah, kind of.
You're gonna look it up?
I will. Which is dumb because bacitracin is fantastic with cuts and stitches and
Like, what are we gonna do?
I'll see if I can find anything. Sometimes those stupid things like that happen because it's like the corporation itself chooses to do that versus like the FDA or something like that. Does that make sense? Anyway, so we have polymyxins. You have polymyxins A through E. So we have A, B, C, D, and E. Currently, polymyxin B and polymyxin E are the ones that are used in clinical practice. They're most effective on gram-negative. They're not usually absorbed orally, so they're mostly topical, or IM. But they produce intense pain. So you want to watch for phlebitis and slow the infusion rate. Have the nurse slow the infusion rate. Have the RN. Okay, here's your bacitracin. It's the ointment available over the counter. It's very widely used. Severe side effects include renal damage and ototoxicity, but like I think you'd either have to take it orally or use a heck of a lot to get that. So if you use it as directed, these side effects should not happen. And then we have metronidazole, which is another peptide, which is widely used for abdominal surgeries. Can be added to a multi-drug regimen to reduce antibiotic resistance. So go back. Yeah, peptides are kind of like a group. Oh, they're kind of like a weird group that include antimicrobials, antibiotics, antifungals, stuff like that. They're like a group. But I think bacitracin and metronidazole are the only ones you need to know on there. If I remember right. So, alcohol is a big contraindication or interaction with metronidazole. It gets them very sick.
They can't have one day for me.
Alcohol or metronidazole?
Alcohol.
Yeah, if they're going home on metronidazole,
0 days.
0 drinks. From what I hear, you can get pretty dang sick.
Can't have one of them. Learn from experience 1 or 2 times.
There you go. There you go. So, under side and adverse effects, third line down, what does that say? Super infection. Who remembers what a super infection is?
Yeah, yeast infections, brush, something else.
Diarrhea, E. coli.
Diarrhea.
What were you saying, Amy? Mm-hmm. Yep. So, you want to watch for super infections. Okay, and then monitor lab values, monitor eyes and nose. And then they do have an immediate release or an extended release. And if it's immediate, you take with food. If it's extended, you don't take with food. Anyway, so this is given a lot with abdominal stuff, especially abdominal surgeries. And you'll see it with other medications, a multi-drug combination. All right. We're almost done. Almost done, guys. Any questions on peptides? You want a pee break? Okay.
I get a lot of coffee.
Metronidazole can be IV as well. Yep. This is our last section that we have to cover. Okay. HIV. You guys remember this from like pathophysiology and med-surg and I don't know, whatever other class would you have. Okay, so it's a virus. It causes profound loss of the immune function. There are 2 primary types of HIV, HIV-1 and HIV-2. 99% of the AIDS cases are caused by HIV-1. So they usually, when they say HIV, they're not going to differentiate because 99% of the time it's going to be HIV-1. a different type. Different type of HIV.
It doesn't, yeah.
I don't know.
Creative.
Good question. Okay, so transmission occurs from exposure to body fluids, most commonly blood or semen. Sexual activity or contact of infected fluids, broken skin, mucus membranes, or needle sticks can transmit the virus. Newborns can become infected through childbirth or breastfeeding. And then the majority of patients with HIV are men who have sex with men. Kind of how it kind of came. Well, I guess the stigma with that goes with that. Probably. Oh, and the band plays on? Yeah, probably. I'm sure they had all sorts of names for it. Got a huge stigma around it as well. So it just goes through the stages. We know it attacks the T4 lymphocytes. And then a lot of times when they test for it, they'll test the CD4 receptors. So you guys can read through the pathophysiology of it. Patients experience sore throat, fever, rash, malaise, weight loss. It can last for a few weeks. They might assume they have cold or the flu and will rarely seek medical attention. And this is the acute retroviral syndrome when that happens. Okay, and then when the T4 lymphocyte count drops below a critical level, then that's when the patient begins to experience the opportunistic diseases. If left untreated, the patient will die. Who are you talking about? Oh, I know. What a cool guy. His vocal range was amazing. Okay, so treatment of HIV is difficult due to the latent nature of the virus and the development of resistant strains. Surprise, surprise. So we do have some pharmacotherapy now that's available. It's not a cure, but it has resulted in therapeutic success to the point where people will, like when they get tested as follow-up, it won't show that they're positive for the disease anymore. Does that make sense? Their count is so low that it doesn't register. And then I have listened to a couple podcasts in the past, and some people say when they're below that level of when they're in that level of undetection, that it's not spreadable either. But I don't know. And then transmission from mom to baby has been dramatically reduced because of these treatments. So, and then therapeutic goals of these medications are to reduce the HIV-related morbidity, prolong survival, improve quality of life, restore and preserve the immunologic function, suppress the viral load, and then prevent transmission. To anybody, really. Not just mother to child, but to anybody, I would think. Okay, so they do have treatment failures, and it happens because of adverse effects. Some people don't like the adverse effects. Lack of adherence to drug therapy, because this is something that if they stop taking the medication, their viral load will begin to increase again. And then we have started seeing an emergence of resistant HIV strains. And then there's sexual lifestyle adjustments that are going to be necessary. And then education on safe sex practices. Can't get more safer than that. Take yourself in. Okay. Let's see if this works.
I'm never calling. Well, I get conscious for that part. It's just like,
Can you guys hear that online? No? Okay.
or fitting poncho. Your dad didn't wear a poncho. People poncho that for days.
Nope, not that one.
It's the little ball on top of the knees.
Okay, let's try that maybe. No, still haven't figured out the sound stuff. I swear to you guys, it was working the other day.
HIV/AIDS has taken the lives of over 39 million people worldwide, despite our efforts to prevent, treat, and better understand it. But with 35 million people currently infected, what exactly is it, and are we close to a cure? To contract HIV, the virus must enter the bloodstream, and it's often transmitted from infected bodily fluids like blood, semen, vaginal fluids, or breast milk. Once inside the bloodstream, HIV targets a variety of cells, but most specifically the T helper cells, which are a type of white blood cell that play an essential role in our immune system and fighting infections. The outer envelope of HIV is covered in glycoproteins, which mutate frequently, ultimately tricking the T cell receptors to not recognize the virus. Once attached to specific proteins on the T cell, it begins to fuse the membranes together and eventually enters the cell, where it releases 2 viral RNA strands and 3 essential replication enzymes. Because HIV is a retrovirus, the RNA is transcribed into DNA, represented here by a zipper of 2 RNA strands transcribing into DNA. This DNA is then integrated into the host cell's genome. This makes the T cells treat the viral genes like their own, which causes them to make more copies of the virus. These then leave the host cell and mature, ultimately seeking more T cells. The virus is particularly difficult to treat because its mutation rate is so high. Overall, the replication process creates more than 10 billion new virions each day. During these initial stages of replication, called the latency period, a person may not show any major symptoms for up to 8 years. If not treated, the HIV eventually kills off the specific T cells it infects. When these T cells fall below 200 cells per cubic millimeter of blood, it becomes acquired immune deficiency syndrome, or AIDS. After progressing this far, the immune system becomes suppressed and is much more susceptible to cancers and opportunistic infections such as pneumonia. A person doesn't die from AIDS, they actually die from an illness that the body could not fend off. Nowadays, there is medicine that helps fight these opportunistic infections, like Daraprim, which was recently in the news when Martin Shkreli of Turing Pharmaceutical decided to raise the price from $13.50 to $750 per pill. There are also antiretroviral drugs that slow the virus down by blocking certain enzymes which are required for the virus to multiply. Similarly, those without HIV but at high risk of contracting the virus may take pre-exposure prophylaxis, or PrEP. This works similar to antiretroviral drugs by blocking the enzyme reverse transcriptase. Thankfully, there is hope for a cure. A small population of people are immune to the HIV virus because of a mutation linked to the T cells. In one case, an HIV-positive subject received a bone marrow transplant, meaning they were given new stem cells that generate different T cells, and within 20 months, there was no evidence of the virus in their bloodstream. Though this is very individualized medicine, it certainly opens up the possibilities of generating HIV-resistant cells. Combine this with other therapies and preventative measures like condoms, clean needle programs, and safe blood transfusions, and HIV/AIDS may one day be a thing of the past. Your sharing of this video is much appreciated in the effort to help spread knowledge and awareness.
Okay. So I don't know if that went over to you guys online or if it was echoing or whatever, but I have the link to this in PowerPoint, and you can also look it up on YouTube. So you can see it again if you want. Kind of interesting stuff though, right? Yes, that is the right answer. Nope.
HIV/AIDS has taken the life.
Let's go on. Okay, so there are 6 classes of antiretroviral drugs. That's what they're called, antiretroviral, to treat HIV. The ones in blue are on your list. Those are the 6 classes. So the standard treatment includes multiple drugs. Multiple drugs. Not what I want to say, but it puts my point across. So you'll take, and it, like the guy said in the video, it's very individualized. So each person's going to be different, very individualized. Probably go to a special HIV doctor, stuff like that. So we've got the NRTIs and NRTIs, and then the PIs. And then we have the INSTIs, FIs, and the CCR5s. We're going to focus on the first 3, though. Okay. So here's the first one. Zidovudine. ZDV. So that's one of the NRTIs. Just really the takeaway from this HIV unit is just to know a little bit about the drugs and be able to pick them out of a crowd and be like, oh, that's an HIV drug. And know a little bit about them, right? A lot of these drugs interact with a lot of other drugs. Okay. And then just know what you're going to be watching for. Changes in HIV symptoms, watch for opportunistic infections, monitor your viral load and the CD4 counts, monitor liver function. Okay. Here's your tenofovir. Now, in the section that talks about Hep B, it's just called tenofovir. In the section that talks about HIV, it's called tenofovir disoproxil fumarate, or TDF. They're really the same thing, okay? And then we have this tenofovir alafenamide, TAF, which is really just a newer version of the TDF. But they're all pretty much the same thing, okay? Tenofovir treats Hep B, treats HIV. Okay, there's your Hep B exacerbation again. That's only if the person has Hep B, though. If they stop taking this med. Okay. Anyway, so just realize that they are the same thing. Even though in the HIV part you have the added disoproxil fumarate. And like I said, the tenofovir alafenamide, that's just the newer version with slightly less side effects, less severe side effects. Efavirenz, EFV. Good stuff. A lot of these cause, like if you look at the side effects and adverse effects, that's one of the reasons for compliance problems is just because of the side effects that happen. And you're taking multiple drugs of these, so you're getting all these side effects. And so sometimes you have a hard time with compliance with these patients. Now, I have a childhood friend who, anyway, now lives in California, but he ended up getting AIDS, and I'm sure he's on a lot of his medications, and he looks like as healthy as a horse. He does he doesn't go cross country. I think he goes up and down the coast of California, like raising awareness, bike riding, raising awareness for HIV and AIDS and stuff. And he looks great. I'm sure he's on all these medications, but with when you're able to, decrease that viral load, then, we can extend life expectancy, quality of life, decrease all those opportunistic infections that can happen. Yeah.
Do you ever stop taking the antivirals when the viral load count gets really low? I mean, what about magic consonants?
So that's the thing, is they can take these medications and the viral load can become so low that it's undetectable. So like if they were to take a test for AIDS, like if, they're like, oh, we're going to test you, see if you have that. The viral load's so low that it won't show up. So technically, yeah, this is not a cure. So this only works when they're taking the medication. If they stop taking the medication, then the viral load will increase and they can be back where they were before. And potentially worse if, it progresses. Mm-hmm. So yeah, lots of drug interactions. You can look in your book for like the whole list, but it is pretty big. Oh, well, let's go back. Okay. So this patient is on ZDV. Which statement by the patient would indicate further medication-related teaching is needed? Right. Two is the right answer because there is no vaccine. So yeah, so antiretroviral therapy will be continued for the remainder of the life. Medication schedule can be adjusted daily depending on the activities. Like, it's very individualized treatment. So they're going to take into account their, daily activities, what they're doing to write up this plan. And then many individuals are able to live symptom-free lives because of medication. Okay, here's just a list of opportunistic infections that are associated with HIV. A lot of them, before we developed a lot of this treatment, Kaposi sarcoma was pretty big. There's your TB, and then a whole bunch of other lists, a whole bunch of other different opportunistic ones. And then occupational HIV exposure. This is covered in your book, and I threw it in here because guess what? That's you guys. That's you guys. So be very, very careful with your needle sticks. Don't have any. There is still that small stigma around surrounding HIV. And so you still are going to have patients that are going to potentially hold back that diagnosis, or, maybe not let you know that they were a high risk of getting it.
I think they got a patient, I think there was a patient that had HIV and he was gay. And the thing was, he didn't tell his family that he was HIV positive, so that was the thing they told us, to not tell his family, or like tell him like this is like what's going on with him or something.
Right.
So that was like a big thing. We didn't want to tell his family that he was HIV positive.
Right. HIPAA is huge with this. Yeah, there's a lot of people who don't want their family to know that they're HIV positive, or, maybe they don't want to tell you that they have, potentially contracted it. Yeah, that's right. Contract. That's the right word, right? Sorry, my mind went to like a contract you sign. I'm like, hey. Anyway. So any needle stick is huge. Even if you, even if your patient's like, oh, I don't have it, like, really go to your employee health, make sure you get tested and all this stuff. They do have this PEP, or the video called it PrEP, but it's a post-exposure prophylaxis, and it does require you to be taking medications for 4 weeks. You will have those side effects, but if it can protect you from getting HIV from a needle stick, then fantastic. Okay. Any questions? No questions. Okay. I have a holiday present for you.
No learning activities?
No learning activity. No learning activity. That's my holiday. That's my my holiday gift to you guys. So yes, dear MedRec. I know I have an email about drug cards, but any other questions about drug cards? No, just the 50. I already counted 50. So just 50 again. Now I stamped all the ones, so if I already stamped them and you turn them in, you won't get credit for them. I stamped every one of them. And I put, if you gave me more than 50, well, actually for everybody, I put how many I received. So if you argue with that, if there's some kind of disagreement with that, then turn in all 100. But, if you turn in 54, then I only need 46. Does that make sense? And I put in the comments how many I got. So hopefully that makes sense.
When are those due?
Next one.